Hi everyone. In continuation with depression and its treatment, we will continue with some of the drugs and their specific uses along with the safety profile and the conditions where they can be primarily used. Now, before we come to the depression treatment, there is a disclaimer that the content of this presentation are for information purpose only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with any question you may have regarding a medical condition. Now, as we have seen in the previous presentations, that broadly speaking, there are 4 to 5 classes of drugs which are used for the treatment of depression. Among them, the common and the older one is tricyclic antidepressants. They are also known as first generation antidepressants. Subsequently, we have selective serotonin reuptake inhibitor, that is SSRIs. We have selective noradrenaline reuptake inhibitor, that is SNRIs, monoamine oxidase inhibitor, and few antidepressants which does not fall into any of these categories, and they are having a very specific mechanism like mirtazapine, nifazodone, bupropion, or ketamine. Now, a general point about the pharmacokinetics of these antidepressants are that if we consider the treatment with antidepressants, mostly the SSRIs, which are very commonly used, and we have seen in the last presentation that SSRIs are the first line treatment as per all the recommendations, almost all the recommendations across the globe. And most of the SSRIs are having a long elimination half-life, and so they are used once in a day. Now, most of the SSRIs, they are metabolized by the liver, and the specific enzyme which is involved in the metabolism is cytochrome 2D6, CYP2D6, and this enzyme is in fact likely to metabolize so many other drugs, and so there is a likely of a drug interaction. So whenever the SSRIs are prescribed, this is important to understand and know that which drug should be given and which should not be given, like oral contraceptives, few hormones, and various other drugs. They may interact with cytochrome 2D6. The escitalopram, which is a very commonly used SSRI in practice today, is used in most of the situations. It is used either as a single drug or it is given in combination with anti-anxiety or other antidepressant drug. And the important point about this escitalopram is that the use of escitalopram should be with care in elderly population because it is slowly metabolized in that age group. So using this drug in the patients above 65 years of age should be with care. Venlafaxine, which is SNRI, it is having less potential for drug interaction unlike SSRI. So venlafaxine is a good antidepressant drug, and if we see the pharmacokinetics of venlafaxine requires dose reduction in liver and kidney dysfunction, and same is with duloxetine, which is SSRI, not recommended if patient has got severe liver and renal dysfunction. So these are some of the points, because duloxetine is also very, very commonly used drug for depression, and more than depression, it is also used in other indications I will show you in the subsequent slides. The mirtazapine, which is a drug having a good sedative effect, as we have seen earlier, has got a long elimination half-life of about 16 to 30 hours. And so, because of this, the dose titration should be very, very carefully done, not less than a gap of 1 to 2 weeks time. So you shouldn't increase the dose. Say 15 milligram is the dose of mirtazapine. So don't increase it every day or every alternate days types, but wait for the response at least 1 to 2 weeks, 2 weeks preferably, to enhance the dose of mirtazapine. Mirtazapine also demonstrate the reduced clearance in elderly patients in renal and hepatic dysfunction. So basically you see the antidepressants, most of these drugs, they are to be given with care in elderly population, in patients with renal and hepatic dysfunction. Now coming to tricyclic antidepressant drugs, which is a first generation drug, and we have seen that they are not the preferred drug now because of their potential side effects. So if we see just what are the side effects of these drugs, we see that some of the common side effects of tricyclic antidepressant drugs are dryness of mouth, blurred vision, glaucoma, tachycardia, urinary retention, constipation, sedation, postural hypotension, weight gain, and cardiac problems. So the combination of side effects are if you see the various combinations, they are primarily because of its anticholinergic effect, its antihistaminic effect like sedation, and because of its alpha blocking effect, that is postural hypotension. And important point, the last but not the least, is cardiac disturbances. So while using tricyclic antidepressant, it is important that the patient should have, the history of the patient should be known for its cardiac illness, either it is arrhythmia or any kind of cardiac dysfunction, because tricyclic antidepressants are likely to cause a cardiac problem. So this is about the first generation antidepressant drug. Now coming to SSRIs, as I have discussed that SSRIs are the first line treatment for depression now, and the advantage is that they have a very good safety profile. Unlike tricyclic antidepressants, the SSRIs are a safe class of drug. It's a safer class of drug. Primarily, it doesn't have any cardiac problem except paroxetine, and that too has got a congenital heart. Means if it is given to the pregnant female during the first trimester, paroxetine may cause congenital heart disease. Otherwise, there is no cardiac problem with any of the SSRIs. There is no anticholinergic side effects, so no dryness of mouth, no urinary retention, no constipation, etc. There is no sedation again because of no antihistaminic effect, and there is no risk of partial hypertension. So if you consider about elderly population who are more prone for these prostate problem, more prone for urinary disturbances, more prone for ocular problems, in such age group, SSRIs again makes the first choice of drug. But there are certain side effects which are particularly to SSRIs, and it is because there is a stimulation of 5-HT2 receptor, because the mechanism what we have seen earlier, that these drugs, they prevent the reuptake of 5-HT through the presynaptic neurons, and because of this there is more accumulation of 5-HT into the synaptic junction, and so 5-HT2 receptors which are present on the postsynaptic junction, they are stimulated in excess and leads to so much of problem, or some of these problems, and they are insomnia, that is loss of sleep, anxiety, decreased sexual desire, erectile dysfunction, anorgasmia, and worsening of depression. So when you start treatment with SSRI, it is likely, especially in during the initial phase of treatment, it is likely that patient may complain of loss of sleep, or decreased sexual dysfunction, or sexual problems, or there could be some worsening of symptoms. But it is just because of accumulation of 5-HT into the synaptic junction, causing overstimulation of 5-HT2 receptors, which gradually, with due course in time, it fades away because the receptors, they are down-regulated. So by and large, we see that these class of drugs are safe and they are preferred treatment for depression. Now, SNRIs, which are also reuptake inhibitor of noradrenaline. In fact, they prevent the reuptake of both 5-HT as well as noradrenaline. So they will have some effect or some side effects like SSRIs only, but the magnitude of side effect of SNRIs are lesser as compared to SSRIs. And in this class of drug, venlafaxine, which is also a very commonly used drug, has a congenital cardiac issue. Means if it is given to the pregnant female in the first trimester, during first trimester, there is likelihood. So two drugs, one is paroxetine in the SSRI class and venlafaxine in the SNRI class, they have the issue of congenital heart disease. Otherwise, these drugs are very safe for cardiac patients. Now, these drugs are, you can say, other class of drugs. They are miscellaneous, you can say. Mirtazapine, which causes sedation. The side effect can be somnolence, increased in appetite, weight gain, and rarely it can cause agranulocytosis, and so the risk of infection is increased. So it is important that mirtazapine, because of its problem on the appetite and weight gain, etc., if you are giving this drug to the patient of high overweight patients or obese patients or diabetic patients, etc., where there is likelihood of metabolic disturbance, this should be given with caution. And mirtazapine, as we have we have seen, and again to emphasize it, that mirtazapine is preferred antidepressant drug for the patients who have got insomnia as the major symptom. Now, nifazodone, which is a drug not a very preferred agent. In fact, it has got a report of hepatotoxicity, and several countries around the world have banned this drug. It is not available. But still, this drug is available in US with a black box warning of hepatic dysfunction. Bupropion, which we have seen is a drug used for depression, has some side effects like anxiety, tachycardia, hypertension, tremors, irritability, constipation, reduced weight, and reduced appetite. Now, the last two problems, side effects, that is reduced in body weight and reduction in appetite, is exploited sometime in patients overweight, in overweight patients who are suffering from bulimia, though it is not a recommended use of this drug. Bupropion, the important point to note is that it may precipitate seizures, and so if the patient has got a history of epilepsy or any other type of seizure, this drug should not be used. And also, this problem of seizure is found to be more because of its Cmax. Once you give this treatment, the peak concentration of bupropion is likely to cause this problem, and to avoid this peak effect or to reduce the Cmax, the ER formulation, which is extended release bupropion, has got a lesser risk of seizure. So if at all bupropion is to be given in patients with a history of seizure, it is recommended to give ER formulation, not the immediate release formulation. The monoamine oxidase inhibitors, we have seen that they are also used as a second line treatment, sometimes third line treatment, along with other antidepressant drug. The problem with MAO inhibitors are the problem of hypertensive crisis, because they are very likely to cause food interaction and also with drug interaction. Now, this food interaction is primarily with the food which has got tyramine in this, and as you know that monoamine oxidase inhibitor, they inhibit the metabolism of monoamines by the enzyme monoamine oxidase, and so because of this there is more accumulation of sympathomimetic amines, and later on these sympathomimetic amines which get accumulated because you have blocked the enzyme into the neurons, and so there is no more further metabolism of sympathomimetic amines. They get accumulated and then they release suddenly into the synaptic junction, causing immediate hypertensive crisis problem. So those foods which contains tyramine, because tyramine is converted to noradrenaline, etc. So tyramine containing food are like soya, beer, chocolate, cheese, red wine, dried meat, fermented food, etc. So all these food, if taken by the patient who is taking monoamine oxidase inhibitor, there is a likelihood of causing hypertensive crisis, where there is a sudden increase in blood pressure to a very significant extent, causing emergency problems. MAO inhibitor can also be hepatotoxic. Some of the MAO inhibitors are also hepatotoxic. So it is very, very important that the food should be avoided if the patient is taking monoamine oxidase. And the same is with a drug. Any drug which has got sympathomimetic effect, or any sympathomimetic drug, is likely to interact with monoamine oxidase inhibitors. Now, to another problem which is noted with some of the antidepressant and other drugs which they are given together is serotonin syndrome, and this problem is as a result of the accumulation of 5-HT at the synaptic cleft. So it can happen even with a single SSRI or a single SNRI, but the chances are very, very less. But if these drugs are combined with, say, monoamine oxidase inhibitors, then the chance of serotonin syndrome increases. So you should not combine antidepressant, say SSRIs, SNRIs with monoamine oxidase inhibitor ever, because if they are given together, there is a likelihood of giving serotonin syndrome. Similarly, if the antidepressants are given along with some of the anti-migraine drugs, this problem of serotonin syndrome may occur. And some of the psychedelic drugs are psychostimulant, psychotomimetic agents like LSD and psilocybin, etc. They can have this problem. Now, this 5-HT syndrome or serotonin syndrome is due to the interaction, or there is more excess accumulation of 5-HT at the neuron level into the synaptic level, and so there is excessive side effects in form of hypothermia. There is rigidity, there is tremors, there is autonomic instability, there is a confusion, irritability, and agitation. So serotonin syndrome is very unpleasant side effect of these drugs. So the precaution is to avoid this kind of problem is that if you are giving these two drugs together, there has to be kind of a gap of certain 14 days or 7 days depending on the type of antidepressant which you are using. So for example, if tricyclics and SSRIs are to be given, they should be given only after 14 days of discontinuation of monoamine oxidase inhibitor, because the effect of monoamine oxidase inhibitor may persist for 2 weeks. So if you are giving tricyclics or SSRIs, you wait for at least 2 weeks time before starting the treatment with these drugs. If you are giving fluoxetine after monoamine oxidase inhibitor, a gap of 5 weeks is required, because if you are giving monoamine oxidase inhibitor after fluoxetine, a gap of 5 weeks is required, because fluoxetine has got a very long half-life, and so the gap of between fluoxetine and monoamine oxidase inhibitor should be around 5 weeks. Similarly, the venlafaxine can be started after 7 days of monoamine oxidase. So these are the number of days between the antidepressant drug and monoamine oxidase inhibitor to avoid the problem of serotonin syndrome. This is a very common question asked for the students, that why antidepressants and monoamine oxidase should not be given together, or why there should be a gap of at least 14 days between tricyclic antidepressants and monoamine oxidase inhibitor. Now, venlafaxine has got a shorter half-life, and it has got lesser accumulation of 5-HT, so a gap of 7 days is sufficient between drug and monoamine oxidase. Duloxetine, which is a very kind of a short-acting drug, only 5 days of monoamine oxidase inhibitor and duloxetine gap is required. So these are the general recommendation for avoiding or minimizing the risk of serotonin syndrome when you are giving 2 antidepressants at a time, especially with monoamine oxidase inhibitor. There are a few general points for depression which needs to be discussed. One is the remission rate of venlafaxine is better than SSRIs. Now, this is a general remark, because various head-on clinical trial comparing venlafaxine with other SSRIs have shown that the remission rate of venlafaxine is better than SSRIs in terms of response rate. So this is one point which should be noted. Duloxetine, which is a drug for depression, is also used in few other indications like anxiety, fibromyalgia, neuropathic pain, and stress incontinence. So they are the official indication of duloxetine. used for these indications as well because of their multiple effects. Venlafaxine is used in few conditions which are more like an off-label indication with some mixed response, like it is used in autism, also in case of binge eating disorder where there is a problem of overeating leading to obesity, hot flashes in postmenopausal females, PTSD, that is post-traumatic stress disorder, and premenstrual dysphoric disorder. So in some of these conditions, the venlafaxine is tried or it is given with some success. Bupropion, which is primarily indicated for depression and smoking cessation, is also used in disease like ADHD, which is attention deficit hyperactive disorder, neuropathic pain, and weight loss. But these are not a very prominent indications, they are off-label indications and not truly effective in most of the cases. Especially weight loss indication is something which could be worrying because it is not officially approved for that use. Thank you.